Hello, and welcome to another RPD video. Today, we'll be discussing RPD try-in and delivery. After jaw relation records, the prosthetic teeth are attached to the framework with baseplate wax. The patient is able to give the dentures a trial run and allows the dentist to detect and correct any issues prior to processing. It's important to establish that the patient is satisfied with the aesthetics of the RPD and that they can speak adequately with the RPD in place. The dentist needs to make sure that the occlusion is correct on the RPD and the jaw relations are accurate. Afterwards, the patient gives a consent to move forward with processing. If an error in the occlusion is detected, a new jaw relation record is made, the case is remounted, and the occlusion adjusted. A new try-in is indicated to give the patient a final look at the prosthesis before processing. The RPD is then finished through a process of flasking, wax elimination, and acrylic insertion and curing. This is collectively known as processing. During delivery, adjustments might be made on the acrylic resin or the cast metal components. Adjustment of the acrylic resin is common due to the distortion that occurs from the polymerization shrinkage of the resin. If a framework try-in has been performed, adjustment of the cast metal components is unlikely. However, adjustments of the cast metal components might still be needed due to possible distortion during finishing of the partial denture in the lab. The delivery appointment comes next. The dentist needs to confirm the full seating of the partial denture and proper occlusal contacts and aesthetics. This appointment usually comes with its share of challenges in order to achieve the ideal fit and occlusion. In this segment, we'll discuss some of the challenges and how to address them. The inability to seat the partial is one of the initial problems you might notice when trying to deliver the partial. One of the potential causes is the existence of soft tissue undercuts on the edentulous segment. In order to solve this issue, pressure indicating paste or PIP can be painted over the edentulous segments. When attempting to seat the partial denture, areas of binding will be evident through a show-through. These areas are adjusted and the partial denture is seated once more. This process is repeated until full seating is achieved. Another common issue is the presence of a residual layer of PMMA on the guide plates. Those layers are residual layers that should be removed by the lab but forgotten. This layer will prevent the seating of the partial denture. This acrylic resin should be removed while taking care not to adjust any of the metal guide plate. Discomfort is another common complaint during delivery. This can sometimes be caused by excessive pressure. In order to identify those areas, PIP paste can be painted, areas of show-through are marked and adjusted, and tried again. Sharp edges on the denture base are also a common cause of discomfort and should be removed. A good rule of thumb is, if it's sharp to the touch, then it's sharp for the patient. Another common cause of discomfort is the lack of relief of the frenum. Those areas are marked with a Thompson stick marker or a PIP and removed. The process is repeated until no more show-through is present on the PIP. Another common cause is clasp impingement. This commonly occurs due to the distortion of clasps during the finishing of the RPD. The practitioner should try to gently relieve the inside of the clasp initially. If this does not result in any noticeable improvement, then bending the clasps with the appropriate pliers is recommended. Care should be taken when bending cast clasps, as they are not made to withstand excessive bending. Swallowing discomfort is another form of discomfort that usually shows up on later appointments but could also happen during the delivery. This is usually caused by the overextension of the distal lingual area of the partial denture. It is important to ensure that the distal lingual area slopes anteriorly from the retromolar pad area. Insufficient retention can occur due to warpage of the clasp or improper planning and surveying when designing the RPD. It can also occur due to the increased weight of the denture after the teeth and PMMA have been processed. In order to address this issue, we must first identify where the clasp tip engages on the tooth surface. This can be done by marking the clasp tip with a Thompson stick marker and placing the RPD back in place. The clasp tip will mark the area of engagement on the tooth surface. The area can then be dimpled with a football-shaped diamond, and the clasp is bent into position to engage that undercut. The partial denture is then evaluated for retention, and the process may be repeated if needed. Insufficient retention can also be caused by inaccurate clasp engagement into the undercut. This can be caused again by warpage during processing. It's recommended to use the appropriate pliers to bend the clasp back in place. And again, extra care must be taken when bending cast clasps. The last issue we'll discuss in this video is occlusal discrepancy during delivery. Occlusal discrepancy can be minor or major. If the discrepancy is minor, Adjustment with a shim stock and articulating paper is indicated intraorally. However, if there's a major occlusal discrepancy, then a clinical remount is indicated. This includes a gyrulation record, a pickup impression of the partial, then mounting and adjusting of occlusion on the articulator. Thanks for joining us, and we'll see you guys on the next RPD video.